relevant topic. We all know that non-communicable diseases are now the major cause of disease and death, also in low and middle income countries. So availability of medicines is very important and very relevant for the global health development. So this session, A Hidden Tragedy, Why So Many People Still Die of Lack of Insulin, is therefore very relevant for this conference. And I also would like to welcome Professor Hans Hogezeil. My name is Jaap Koot and I'm working in University Medical Center in Groningen, and Hans is retired professor in global health and he used to be my boss. So it is a pleasure to give the floor to my former boss and let him lead this session. Welcome, Hans.
Thank you. Good afternoon. Well, I thought it would be very nice to have our presentation in the big hall, but then suddenly when it is so big, it looks a little bit small, unfortunately. Anyway, I'll give you a small introduction to the topic. Next slide, please. My question to you is, why do you have so many few adults with diabetes type 1 in Africa? And I asked the students the question, and then you get answers like, oh, well, that's because there's different ethnic origin, or there's maybe the healthier food. And then I said, no, that's not it. People with diabetes type 1 never became adults. They never survived their 20th year because there was no insulin. And so that is the question, the diabetes type 1. We'll present to you a little bit more about that. Now let's look here. Here's a rural clinic in Uganda, 2017. I was there. And the interesting thing is, next slide, please. This is the pharmacy. This is not a cupboard in the clinic. This is it. And that's usually what they have for the 1 month. And of course, you will see about 20, 25 medicines, definitely no insulin there. Next slide, please. This is northern Ghana, a district hospital close to Tamale, northern Ghana. I was there, waiting area. And then you say, okay, there's also the pharmacy. The pharmacy? Where's the pharmacy? Well, actually, the pharmacy is that little window you see quite at the very end. That's the pharmacy. And if you look behind the window, this is where this lady is, and she's the pharmacist, and this is what she has. Looks already a bit better, but again, this is the pharmacy. So that's what it is. Those of you knowing medicines will recognize a lot of UNICEF and IDA, generic drugs, etc., but no insulin. This is in Nepal, far away up in the mountains, a primary healthcare, a doctor. And this is, well, she has the pharmacy. I mean, she gives the patient straight away the medicines here. This is what you have, about 35 medicines, and again, no insulin. She said, no, insulin is in the district hospital. Then when you go outside, just outside that place is this pharmacy, private pharmacy. And I asked her, do you have insulin? She said, no, only the district hospital. Okay, but the district hospital can be 100 or 200 kilometers away, which of course is quite an issue when you need your insulin every day. And then there was an interview with an old lady in Cambodia and about insulin, and she had diabetes and she needed insulin, and she said, I wish I had AIDS, because then my medicine would be free. But now I have diabetes and I have to struggle every month to get my insulin, and would I have to pay it myself. So when we talk about essential medicines, we talk about equity and efficiency. And equity is the first thing, you want to have basic things for everybody. You want basic insulin for everybody. And for example, in Tanzania, that is, you'll hear more about it. About 10 years ago, when you had a family with a child with diabetes type 1, and the child needed the insulin and the glucose strips, and the syringes, and that in itself consumed 53% of the family income for the one child. So that means there's no money for the school fees and the school uniforms, things like that. A huge burden. And you saw that after a number of years, the parents simply gave up and couldn't manage. That's why many of these children never became adults. But it's also a matter of efficiency. In the Maldives, or just in the Maldives, and there you have a lot of insulin and things around, but at far too high prices. I mean, 3, 4, 5, 6 times the price. So equity had been achieved, but at huge cost, and there was a problem with efficiency. Now, this is a graph from Tanzania. This is what we like to see, and you will get more of it later, but I want to explain this to you. This is the availability of insulin and NCD drugs in Tanzania a few years ago. On the horizontal line, you see availability. It runs to 100%. And on the vertical line, you see affordability. How many days work for the 1 month's treatment? And what you want everything to be in the right down corner. It should be more than 80% available and less than 1 day wage per month. Now, you see all the NCD drugs being there, and then you see all the insulins, they are the red circles, in the public sector and in the FBO, the faith-based, so the mission hospitals. You see them sort of available, between 10 and 60%, and anyway, too expensive. So it's still not perfect at all. About half, you will see more about Tanzania in a minute. So this is a special session. This was myself for 5 minutes. We'll have a presentation about access to low-middle income countries, access to insulin, by Molly Lepesca and Mark Ewan. They will present a global situation. And then we'll have 2 presentations, one from Peru first, and then from Tanzania. And in the end, we'll have 20 minutes left for discussion and for questions. So, without further ado, I would like now to introduce Molly and Mark. Please come here. I think Molly will start, but you will divide it between the two of you. Yep. Both have been working for the last 9 years with the Health Action International program, Access. They will explain to it what it is. A huge program to analyze, study, and promote access to insulin in lower middle income countries.
Great.
Ladies.
Thank you.
You have the floor.
Okay. Thank you very much, Hans. And I mean, I think all of those photos of the pharmacies, what's striking is for insulin, it needs to be refrigerated. And there was not one, no mechanism there for any refrigeration. So that's another issue. See, so, and thank you so much, Hans, for bringing this to the attention of this conference. This has been Marg and I's life's work for the last 9 years. So we're happy to speak about it with the people here. Marg and I, because we work so closely together, we're going to try and share a presentation. So let's see how that goes. So declarations. So as Hans had already mentioned, insulin and access to insulin is a serious issue around the world, actually. I'm a person with type 1 diabetes who grew up in the US and know firsthand how expensive this condition can be everywhere, and then working in diabetes for as long as I have, what you understand is the inequity across the world is actually really intense, and it varies depending on where you live, so it's very striking. And so one of the reasons we started the Access Study, which is a collaboration with Health Action International and the University of Geneva, is to really understand why these issues exist. What is it about the insulin market that really is creating these inequities? And we've heard a lot about it, but we really wanted to really understand it from a research perspective. And then once we sort of understood it, try and work on some of the interventions we developed in country to see if they could improve access to insulin. So we work together with a group of international experts, which some of them are featured in this photo. And then we have 4 amazing national partners, and you'll also hear from them today in Kyrgyzstan, Mali, Peru, and Tanzania. Oh. Sorry, that one. Okay. So people might not know here that much about diabetes. Currently, there are 537 million people living with diabetes in the world, and this is just the adults. And this number is supposed to rise to over 780 million by the year 2045. Diabetes is often considered a high-income condition, a high-income country problem, but in fact, 3 in 4 adults with diabetes live in LMICs. So there are more than 2 types of diabetes, but these are the main types of diabetes and what we talk about most frequently. There's type 1 diabetes, which is 9 million people we estimate to live with type 1 diabetes. And type 1 is an autoimmune disease, so that means that it's no one knows yet the cause of it, and it's when basically your body attacks your pancreas and it no longer works. There's no cure for type 1 diabetes, and there's only one treatment, and that's insulin. And without insulin, you will die. Type 2 diabetes is a much larger percentage of people with diabetes. There's many causes to it, genetic, physical activity, diet, environment, and this is when your body becomes insulin resistant. There are many treatments for type 2 diabetes, but we've estimated about 63 million people need insulin for their treatment to prevent serious complications. So between the 63 million with type 2 and the 9 million with type 1, there's actually over 70 million people using insulin for their condition. So what is insulin, and why is it talked about so much? Basically, when insulin was discovered in 1921 in Canada, it was considered a miracle because people with type 1 before that time were just wasting away and dying. It was first used in a child in 1922. It was this boy, Leonard Thompson, in Canada. And you can see this is just the difference within months of beginning to use insulin. So this last year, we celebrated the centenary of this discovery. And it's critical in thinking, especially considering we estimate 1 in 2 people in the world currently don't have access to insulin. So you can see here from this chart, you can see this is prior to insulin being discovered. The life expectancy once you were diagnosed with type 1 diabetes was under 3 years at max, so about 2.6 years. And once, as you see, as time goes on and the treatments continue to be developed, the life expectancy past diagnosis rose up to 40 years in 1945. So you can see there at the end, the life expectancy now after diagnosis for people with type 1 diabetes in high-income countries is 65 years. Unfortunately, in low-income countries, we're still at 13 years. So as Hans mentioned before, people who aren't making it to adulthood, this is still unfortunately the case in 2021. So the insulin, we call insulin a miracle, but for people living with diabetes, you just see it sort of as the foundation of a house. Taking care of diabetes every day, managing your care successfully to get to that 65-year life expectancy is very complicated and costs a lot of money and requires a lot of different things that you need every day. So here we've got our insulin delivery devices, insulin pumps, pens, or syringes. You have to test your blood sugar using self-testing, or not pictured here, continuous glucose monitoring. You've got to write down everything and keep everything in your head to adjust your doses versus what you're eating. You have to have access to food so that you can ensure that you're not going to have any lows and potentially go into a coma. So even to get to that 65 years, it's quite actually a lot of work every day for a person with diabetes, and that's in the best conditions. So now that you know a little bit about diabetes, as I mentioned before, 2022 was the centenary year of the first use of insulin. So this provided for us, for people who've worked a long time in access to insulin, a really great opportunity for increased exposure and some movement on access to insulin. There was a resolution on diabetes that included access to insulin, and with that there was targets directly for 100% of people with type 1 diabetes having access to affordable insulin and blood glucose. And there's a global diabetes compact by the WHO. So these things have helped in this moment to really start to push this forward, but obviously there's still a lot to do. So as I said, we're really welcoming the exposure on access to insulin at the moment. What we've tried to do is really take a 360 approach to understanding what are the issues in terms of access to insulin and the insulin market in general. How can we identify the challenges and then work actively on those challenges to improve the issue for people living with diabetes? So these are some of the areas of research that we've already worked on, from looking at the insulin market and the glucose testing market, all the way to speaking to people with diabetes and diabetologists, to understanding what's the cost of production of insulin, and a bunch of other stuff. So what we've identified is this insulin supply chain and some of the complex challenges within it. What I always say is that explaining access to insulin can be as challenging as having diabetes itself. It's not a simple answer, unfortunately, and that's why we're stuck with this problem for so long. But I'm going to speak on most of these supply chain issues. My colleague Marg is going to speak about pricing and availability when I'm done. So the insulin market, for people who might know a little bit about the insulin market already, a lot is talked about in terms of sort of the market domination of the market. So it's a $24 billion market, and it's dominated by 3 companies who have over 90% of the volume and the value of the market. So there is still not that much competition within the market. And what we had found in terms of independent manufacturers of insulin, we found about 39 insulin manufacturers, but a very limited few are actually independent, and most that are only work in the country that they manufacture the insulin in. We also found that the cost of production of insulin is quite low in comparison to what they're selling it for, particularly in analog insulins. There are 2 different types of insulin, and we'll refer to them more in this presentation. Human insulin was developed in the 1980s. It's been around for about 40 years, and typically it's less expensive insulin in most places. Analog insulins were developed in the 90s, and you see them, most of the market share of them in Europe and the US, and they're 7 to 9 times as expensive. So those 2 different insulins, they do the same thing. They cost the same amount to produce, but often you find the analogs much more expensive. Yes, biosimilar companies, which biosimilar insulin would be like generic insulins, have difficulties in that they're often can't compete in terms of pricing with the big 3 who have so much of a hold on the market. And we've also found going forward, and there's many new technologies that are being used, especially for type 1, but often they're not developed with people in lower middle income countries in mind. They're only developed in high income countries, and so there can be challenges in terms of having them be used globally. Oops, I did it again. So project registration really means quality, access to quality products. Because insulin is a biological, it's much more complex for regulatory authorities to assess, and we found inconsistencies in regulatory requirements, not only for insulin, but also for the self-testing devices, which is an issue for patients because they want to be confident in what they're using and can be quite dangerous. And we found that in terms of the human insulin, which is usually less expensive, there's been no regulatory approval from a stringent agency like the EMA of human insulin. So that means people who want to access a generic insulin it hasn't been assessed by a high stringent regulatory authority. So that's why we find it very important to push for the biosimilar insulin inclusion in the WHO pre-qualification program. So on top of this, I mean, of course, affordable access to insulin is very important, and again, we'll talk about that in a bit, but another issue is a lot of countries aren't basically set up in terms of for taking care of diabetes itself. We see a lack of clinical guidelines for both type 1 and type 2 diabetes in many countries, or guidelines are there, but the doctors aren't trained to understand what diabetes is or how to diagnose it or how to care for it. Particularly at primary care levels, they've never even seen diabetes or understand any of the tools that are needed to manage it. There's often a limited understanding by healthcare professionals about biosimilar insulins or quality perceptions. They're used to working with one brand over another brand, so they might not be open to allowing, a different brand, or patients to use a different brand. And there's often a lack of guidance in terms of switching from brand to brand, which can be a little bit difficult for patients, and a lot of clinicians don't understand how to do that. And similarly, for people using insulin, they're often impacted by how a government decides to buy insulin. They may choose to buy one brand 1 year because it's cheap and then move to a different brand. And as I mentioned before, with prescribers, they don't know which brand, they don't know how to adjust their doses based on the new brands. And just like with clinicians, there's often a lack of adequate training in terms of people using insulin. Diabetes is about 90% self-management, and if you're not empowered to understand how to actually manage your diabetes yourself between food, testing, and your insulin, you're really at a disadvantage in terms of having a thriveful life with diabetes. And then, of course, stigma and discrimination and lack of empowerment are big problems really around the world, but there's often a lack of understanding so that people don't feel comfortable, for example, injecting themselves in public or testing their blood sugar or even talking about diabetes because it might look like a weakness to others. And another issue, which we're going to just show a video about that really illustrates this point, I think, very well, is availability is often low or irregular. So often, even in the best circumstances, even if a person knows how to use their insulin and they've been trained by a doctor, they can go to a facility to get their insulin and there's nothing there. And maybe they've traveled 4 hours to get to this facility. And then if it's in the public sector and it's supposed to be for free, they might have to then go to the private sector and pay out of their own pocket for that insulin. So they've taken a whole day off work, they have to pay out of pocket, and it might not even be the exact thing that they wanted. So there are many issues in terms of dispensing insulin that really prevent people from not 100% access to insulin. So I'm going to show this video that from Peru, and then Mark's going to speak about price and availability afterwards. Okay,
la diabetes en sí para nosotros ha sido realmente muy complicada. Tiempo, tanto en pasarla con los hijos, ¿no? Y mucho más económicamente.
People with this condition, especially when they need to use insulin in different areas of Peru, you find this huge difference to achieve an adequate treatment.
Lara, teniendo canon petrolero, no tenga un hospital, pero así propiamente dicho. Lo que hay en Talara es un centro de salud. A una persona diabética siempre van a ir complicando. Y esa es tal vez la frustración, ¿no? De tener que hacer un viaje de 2 horas, que cuando es periodo de lluvia se convierten en 3.
Este problema del difícil acceso y abastecimiento de la insulina por parte de los pacientes tiene un gran impacto en el manejo y tratamiento de la diabetes. Cuando llega a nuestras manos, llega ya un paciente complicado, con problemas renales, con heridas en el pie, pacientes con ceguera, entonces ya es un poco tarde.
Y esto es cuando sí hay, sí tengo insulinas que me dio el Estado, ¿no? Pero cuando no hay, tenemos que hacerlos estirar como podamos, ¿no? Él tiene que saltarse los horarios de inyección o hacer actividades, ¿no? Para poder comprarlo, pero ya de manera privada en farmacias y son carísimos.
Okay, that was a snippet from the video that we produced a couple of years ago, and I think even that small snippet really illustrates a big problem we have. And of course, in low and middle income countries, unfortunately, a lot of people are having to pay out of pocket for their insulin. So what we've done a number of price surveys now of insulin, and clearly prices are high, they're variable, and there's certainly difference between the price of human insulin and analogues. But the biggest burden is falling on people who are paying out of pocket. Molly talked about the dominance of the big three pharmaceuticals, the multinationals, Novo, Lilly, and Sanofi. There are other manufacturers of biosimilar insulins, but as Molly said, they have problems with getting into markets that are so dominated. But where we do find the biosimilars, generally they are cheaper than the originators, but not always. It depends on the country, and that's why it's so important to measure these things. I remember it was in Kazan province in Russia. We actually found the biosimilars were higher priced than the originators, but that isn't the norm. As Molly said, prices that people have to pay are way above the cost of production for both human and analogues, particularly analogues. So there is scope for prices to come down, that's for sure. And we'll look at some prices shortly. We also have to remember, it's not just the insulin, it's the delivery device and the blood glucose monitoring devices as well. So they all have a factor to play in the total price of treatment for people living with diabetes. Oh, no, sorry. Let me go back. Okay. If we look at the affordability, because after all, that's what we want. We want insulin to be affordable. It's one thing to talk about price, but actually we want affordability. And in surveys at this time, we were basing it on how many days the lowest paid government worker has to work to be able to afford 1,000 units of insulin. So this is like the person that sweeps the floor in a government building. This isn't a high-paid technical person. It's an unskilled person. And this was a study in 13 low and middle income countries. And you can see in the public sector, private pharmacies and private hospitals, there for human insulin, you can see on the left here, you'd be working around 3 to 5 days just for your insulin per month. 3 to 5 days. That seems a lot. And remember, you know, there can be other people in the family that also need medicines, and there can be comorbidities as well. This is just for the insulin, for human insulin. What about the analogues? Well, you can see on the right-hand side, you're talking a week to even 2 weeks, depending on the country and the sector, for a month's supply. So you can see how unaffordable insulins are. Now, I mentioned it's not just insulin. People have to pay for the delivery devices and the blood glucose monitoring devices as well in many, many countries. Even in countries where insulin is provided for free, we often find they do not provide the meters and strips for free. People have to go and buy those. Now, this is Tanzania, 2019, and you can see public hospitals, faith-based organisations, private pharmacies and private hospitals. We track the prices of the insulin, which is in the blue, the syringes, blood glucose meters, and we worked on the assumption a meter would last 2 years, and test strips, and this is based on 60 strips used a month, so it's 2 tests a day, which is far lower than the recommended levels for people living with type 1. And you can see it is, of the total cost, the biggest component of that was actually the test strips. It wasn't the insulins. And this is all human insulin. It's a mix of regular and NPH. But you can see overall, people are paying around the sort of $35 to $40 for a month's supply. And that would take 8 to 10 days' wages of this lowest paid unskilled government worker. So this really shows it's not just the price of the insulin that can be really driving up the unaffordability, it's the test strips as well. So what are some of the challenges here? Well, governments need to procure effectively and efficiently, and that's not always the case. We see examples where governments are not tendering. They may be buying from a local private distributor or importer. It would be better if they did tender. I'm sure they would get lower prices, but of course that needs to be seen. But there certainly is examples of inefficient procurement. Inadequate assessment of need, inadequate budgets, which all means that impacts availability in facilities. When people go to get their insulin, it may not be there. There's, like with so many medicines, there's lack of transparency on prices, both what the government pays and also on what people are having to pay. So there needs to be far greater transparency, and certainly for governments, if there was more transparency, it would sort of aid them to understand, is this a price that's similar to my neighbouring countries, or is it really high, or is it a reasonable price? But of course, a number of companies do ask governments to sign confidentiality agreements so that they cannot share the prices, which is difficult because they themselves would like to know what other governments pay, but they are hindered from telling anyone what they pay, and that's a real problem. We need to stop these confidentiality agreements and have transparency. And of course, in supply chains, there can be add-on costs. So, you know, you start with the manufacturer's selling price, and there can be all sorts of add-ons put onto insulin and meters and strips, as well as taxes and tariffs. I'm sure you've seen these yourself. They can be all sorts, and it's important to track what these add-ons are. And certainly when we've done it for essential medicines, it's been surprising in some countries what sort of add-ons are put on essential medicines. But we're actually tracking at the moment some meters and strips to see what the add-ons are there in some countries. But certainly these add-ons drive up prices, and they need to be regulated and enforced and controlled. Now, what about insulin availability? Of course, it must be there when it's needed. And what we've found, there can be a real poor availability, particularly further out you go from the capital. Sometimes availability can be good in the public sector or private pharmacies in the capital, but the further you go out, it can fall off dramatically. This is just some recent data in 3 low and middle income countries in Kyrgyzstan, Mali and Peru. You can see on the left, this is NPH human insulin. And you can see in the public sector, across those countries, it was below 60%. This is a mean across the different regions that were sampled. In the private pharmacy, we can see in Mali, it was 100%, which is just as well because the latest data out of Mali shows it was no availability in the public sector. You must go to the private pharmacies to get your insulin. And at the moment, it's costing about $10 for a vial, which you can understand brings up massive affordability issues for people paying out of pocket. But here you can see in Kyrgyzstan and Peru, much lower availability in private pharmacies. So if you go to the public sector, the insulin isn't there, you then have to go to another sector to try and find it, and you'd be very hard-pressed in Kyrgyzstan and Peru to find it based on the data that was found in these rounds of data collection. The long-acting analogue insulins, glargine and detamir, far lower availability, although in Kyrgyzstan it had higher availability than human insulin. So availability is also a problem, not just affordability. So, what can be done? It's really important that countries really do research and understand the issues and the problems in their country. When we look at different countries, we find different scenarios of what really is the problem. So I think first and foremost, you have to really do research and understand the market in your country. And also, it's really important to engage in a meaningful way with people living with diabetes who need insulin. That is absolutely crucial. Some of the barriers, well, clearly there is a lack of competition. 100 years we've been using insulin, and we still have a lack of competition. And I think anything that can really provide greater competition will drive down prices. Of course, all products on the market must be quality assured. That is an absolute given. And it's important that regulatory authorities do a really good job, particularly in the assessment of biosimilars, which they have less experience in some of the low and middle income countries in assessing. But regulatory authorities must be adequately assessing so that all the insulin on the market is quality assured. Pooled procurement, well, within a country, often we find decentralized procurement, and that often means the different people procuring the insulin are paying higher prices. If they pooled their procurement nationally, they'd do better. And I think we're going to hear a lot more about this from Peru. And I talked about efficient government's procurement. That's very important. Good understanding of need and an adequate budget so that all the people that need the insulin can get it. Well, first of all, of course, you need an NCD strategy in a country, and as a part of that, a strategy on diabetes. I mentioned person-centred approaches and policies, so important. And I think it's important to recognise there is a difference in the needs of people with type 1 diabetes to people living with type 2. But each must be adequately discussed to make sure their needs are met and action taken. Healthcare professionals and people living with diabetes who use insulin must get training. You know, often we see people who are using meters and strips but are not adjusting their dosage of insulin based on the results because the training wasn't there. And when we started working in Kyrgyzstan, family doctors were saying that they've actually never used a blood glucose meter. It's sort of hard for us to believe that, but that was the case when we started working in Kyrgyzstan. So a whole lot of training of doctors has had to happen. We mentioned about the involvement of people living with diabetes, and true partnerships are needed, really true. The other thing that it's become very apparent in focus groups we've had in our countries we're working in is the issue of stigma. And I think we have to now consider this is also an access to good treatment, a barrier to treatment for people. There certainly is, as they told us, a stigma. If you need insulin, you're injecting. And I think there was a good example in Mali, women who were about to be married really didn't want their husband's family to know that they were having to inject insulin because they were living with type 1, and they were actually stopping treatment before the wedding out of fear that the wedding may not happen. But we need to understand more about stigma, and certainly that is something we want to work on in the Access study. Partnerships, Yes, they are important, but I think we have to have clearly defined roles and good transparency and partnerships. But as I say, they are important too. I've mentioned transparency. I think I'm going to go to my deathbed talking about transparency. It's something we all talk about, but have we achieved it? No, we've got a long way to go in this. And I think a lot of work is still need to be done to improve transparency. And I'd love to see far more transparency in the insulin market, the diabetes market, as we should with all other medicines as well. Certainly a global repository of government procurement prices would really help governments. I often feel very sorry for procurement officers, and in some countries it could be a person working in total isolation, trying to do the best job they can. They get an offer. It's very difficult for them to know, is this a reasonable price or is it not? Because they don't know what others are paying. And I think we've got to move on from this and have a global repository so that government procurers can look up and see what others are paying. We certainly need to regulate the supply chain and these markups and look at other ways, maybe, rather than markup based on the value of the medicine, it should be a different way to remunerate those in the supply chain. Taxes. Well, I'm all for removing taxes on essential medicines, but it's very important that you have a regulated supply chain, because you may remove a tax, but you may find someone else in the supply chain ups their markups. So in the end, the person paying out of pocket doesn't benefit. So I think I would like to see taxes on essential medicines removed, but there has to be a good oversight and good regulation and good enforcement in the supply chain to make sure the savings reaches the end user. We really need regular monitoring of this market. It is dynamic, it's changing, and we really need to know about availability, about affordability, about rationing, and about testing levels to see, what's the price of test strips? Is that hindering testing so that people are not testing as much as they should? I really think countries have to be regular monitoring, and not just a one-off survey now and again, but a continuous collection of data from facilities and households about what is really going on, because that will inform policy. And I think it's absolutely important that countries do act on the findings to make sure that people who need insulin are getting it, can afford it, are testing in the right number of tests and everything, and are adequately and correctly using their insulin. And I think education comes with this as well. So I think that is it. Thanks for listening to this. I hope that's been informative.
Thank you all. Thank you, Liz. Well then, so we have heard it's big business, a lot of profit being made, high prices with low production cost, monopoly by 3 main manufacturers, a lot of interesting things from a pharmacological or pharmacy and distribution point of view. We continue. I used to say to my students, I said, okay, they were my Millennium Development Goals. They are your Sustainable Development Goals. So I'm very happy that we have now 2 more presentations by PhD students who will tell us about what they are doing in this specific field. I'll first invite Janet Tenorio, who is from Peru. She's a pharmacist and a master in epidemiology. She's a member of Crónicas, which is a center of excellence in chronic diseases in Peru. And she's now a PhD student in global health in Geneva. You're very welcome.
Thank you very much. Yeah, it's working. Thank you. I'm happy to be here to share some Peruvian strategies and experiences to improve the access to insulin. Okay. Okay, thank you. Let me start placing Peru on the map. Peru is a South American country with an immense cultural heritage and a diverse population. Economically, Peru has grown steadily during the last years. However, the political instability has affected the economy as well as the healthcare provision and policies. Focusing in our topic, diabetes. Diabetes is a really important public health problem in Peru. The prevalence of diabetes type 2 is around 7%, and the incidence is around 20 persons per 1,000 persons per year. And for diabetes type 1, the incidence is 0.4 100,000 persons per year. However, we need to consider these numbers cautiously because they are based on estimations, since in Peru there's no harmonized registry for the number of for the cases that are prevalent or incident. In 2018, with the AXIS project, you are quite familiar with this graph because Mark and Hans have presented something already. We assess the price, availability, and affordability in 6 regions in Peru in the private and the public sector. We found that human insulins, regular and isofan, are affordable. So people need to spend less than one daily wage to get their treatment. However, is not found in all the healthcare facilities. On the contrary, there's no analog insulins, but analog insulins can be found in the private sector, but not in all of them, and the prices are really high. For example, to get a treatment for 1 month, a patient can spend up to 14 daily wages. Let's talk about bulk procurement for human insulins. Let me first explain a bit about how the healthcare system works in Peru. Peru has both public and private providers. The main public provider are institutions managed by the Ministry of Health. Most of the patients receive care, most of the population receive care by institutions in the Ministry of Health. And recently, because of the strategy of universal healthcare coverage, those who has not an insurance paid by the employer or can afford to a private insurance receive healthcare services in institutions in the Ministry of Health. Consultations and medicines in the Ministry of Health are free of charge. However, there are long waiting lists, overcrowded services, and shortage of medicines that hinder patients' access to insulin. Peru also has an authority, an institution, who monitor and regulates the procurement of medicines. This institution is named Senares. And with the AXIS project, we get access to the tendering process and the purchase price of insulin from 2015 onwards. And according to Senares, the institution, regular insulin was 18 Peruvian soles, and isofan insulin was 45 Peruvian soles in 2014. But later, different strategies were held to improve the bulk procurement processes, and it's mandated that up to 80% of the medicines, of the essential medicines, needs to be acquired through bulk procurement. Also, the strategy has improved because they allow that other institutions besides the Ministry of Health can participate in the pool procurement. For example, the Social Security or the Armed Forces. So the volume of insulin or medicines, including insulin purchase, has increased, and the prices has decreased, as you can see in the evolution from 2015 to 2020. The price at 2020 is almost half of the prices in 2014. So we also were interested to know about what are the challenges to access to insulin in Peru, but also some positive strategies. So in the process, we learned that all healthcare facilities managed by the Ministry of Health have a registry of all the medicines that are delivered to patients at pharmacies. So we collected, or we had access, because it's actually it's data that is publicly available, and we assess the trajectories of insulin use in all the healthcare facilities that belong to the Ministry of Health, in all the healthcare, all the level of care, primary, secondary, and tertiary. Let me start with the primary level of care. This graph is plotted for regular insulin, the green one, and for isofan insulin, the blue line. We can see that from 2015 to 2017, almost 0 insulins were delivered in a primary health care, which means that patients need to be referred to a higher level facility, as we saw in the video that Mark presented. Later, thanks to some guidelines and some policy improvement, the delivery of human insulins increased a bit, not so much, but from 2019, there is a steady delivery of regular insulin, but for isofan insulin, there is a steady growth, which is something positive because patients can have access to their insulin in primary health care. So we dare to say that pool procurement has improved the volume of medicines that are available in the primary care level. In this graph, I show you the trends only for regular insulin in both the secondary and tertiary level of care. You can see that there is also, as not steep, there is a growing, but something that caught our attention is that there is a upside peak that is almost 3 times the usual trend. We don't know why. We need to do further exploration. But other interesting thing is in April 2020, there is a downside peak, which coincides with the onset of the COVID pandemic, where a lot of many healthcare facilities were closed, so patients couldn't access to their treatment. This is for isofan insulin. There is also a peak in downward in April for the COVID pandemic, and surprisingly, there is another peak upward from November 2021. We need to explore in detail. But from this and the last graph, something that is particularly or is particular, there are up and downs. And as you know, diabetes is a chronic condition. It's not a seasonal disease. So this behavior can be attributed to the disease itself, but maybe, or probably, there's something related with a supply chain that can be medicines, shortage medicines, or not only negative things, that also can be positive things, that patients can get their access to the treatment for 2 or 3 months. So it means there are peaks in some months. We don't know yet, but there are a lot of things to think about. Also, we saw that there is a steady growing. So there is more insulin that is delivered to patients, but it doesn't necessarily mean that there is a high patient coverage, because as we saw in the first slides, the prevalence and incidence of diabetes is also increasing. So this information is not measuring the patient coverage. So to conclude my presentation, I would like to acknowledge that Peru made some improvements to access to medicine and to access to insulin. And we can see that the primary care level is one of the benefits the most. However, much more needs to be done.
Thank you all. Thank you, Janet. Come. Yeah, so you see, there is a real success story, and please, George, come up. When I was a mission doctor in Ghana long ago, in a big mission hospital, we had no insulin, and when diabetes patients would have come, we would have told them, sorry, we can't help you. It was simply not on our radar to supply it. I suppose there was not much diabetes type 2 then, but the type 1, we didn't see it, and we sort of said, we can't start supplying you. We have no money, we have no way to do that. We are not a pharmacy. Just to say how things are. And when I look at the graphs here, in 2015, there was very little insulin in your system as well. So you can see how it can actually improve. It's a pleasure now to improve the last speaker, George Msengi, who is a medical doctor from Tanzania, is doing a PhD on the topic of NCDs in Germany, in Marburg, on new and novel risk factors for NCDs in Africa. But he will tell us something about the diabetes program in Tanzania as part of the NCD program. So, George, you have the floor.
Thank you very much, Hans. Good afternoon, everybody. So yes, my name's George Msengi, and I would like to take you through a bit on an overview. We have had a lot of issues about the accessibility, affordability, and so much more on insulin, but I would like to take you through about diabetes in Tanzania. Some of the success when it comes to the diabetes story in Tanzania. Yes. So this is my outline. I'll be talking about the country. So we have had a lot of problems when it comes to insulin, so I'll just take you through a very good tropical country, good weather, but also a very good site for recreation and holidays. So the country is in the eastern side of Africa, and as you can see there, that's a map of our country, and the area coverage is around 900,000 square kilometers, and 44% of our land is arable land that is being used for agriculture, and 27% of this land is being used for pastoralism activities. And from this you can tell and you can note that we have a lot of agriculture and pastoralists in the country. Our population, when you'd ask 22 years ago, was 34 million, but a year ago is 63 million. That is quite an increment in our population. And some of the key landmarks, we know that Tanzania is the home of the tallest mountain in Africa, is the home of the Serengeti, which is actually the biggest mammal migration, and that, as you can see up there, is a bit of a mountain, side of the mountain. Back in the day, nowadays there's not so much ice because of climate and the likes, and it's also a union between Tanganyika and Zanzibar. Zanzibar is quite very famous as a tourist recreational site. Now, to go into the diabetes profile and talk about some of the key issues of diabetes in Tanzania. So in the 1980s, not only in Tanzania, but in many low and middle income countries, there was little information that was actually known regarding diabetes. And there was a study that was actually done in the 1980s, and it showed that only 0.9% of our population, and mostly adults by then, had diabetes. But in the 2000, it went up to 1.3%. And apart from that, we had the STEP survey, which is a WHO survey that focuses on NCDs. done in 2012. And in 2012, we actually noted in 38 rural districts that 9.4% of the males had diabetes, and 9.1% of the females aged between 25 to 64 years. So you can see quite the increment in terms of the numbers. And the first study that I was talking about, which was done, a cohort that was done between 1981 to 1987, showed that the patient which were actually recruited then, 21.8% of these had needed insulin. This is disregard of type 1 and type 2. Now, in this study, we looked at the 5-year also survival rate, and we can see that these are the numbers. And the most common cause of mortality when it comes to those patients who are actually not surviving, for the insulin-dependent, it was serious diabetes ketoacidosis and infection. For the non-insulin-dependent, again, we had infection, and 24% had cardiovascular issues. So 3 key basic surveys and reports that I'm going to talk about and will be the benchmark of my study today is number 1, the STEP survey, number 2, the NCDI report, and number 3 is the data health information system, which is real-time data that we gather in our country. And as you can see here, this is a profile that is being shown from the NCDI report of 2020. And one very specific thing to look at here is the 70%. There was a 70% of newly diagnosed just from the survey in itself, but out of this, they had never done their blood glucose measurements. And this is quite very similar to what was happening in 2012. So the previous slide was for 2020, but in 2012, we see that in the survey, which was a country-wide survey, 90% of those who had actually been assessed for diabetes, 90% of them who had been diagnosed had never actually done their blood glucose measurement. And we can see the prevalence on 25 to 64% to 64 years, that 8% of the males and 10% of the females had diabetes. The prevalence is quite very different when it talks about urban and rural setting, especially in a country whereby we have a lot of people who are pastoralists, a lot of people who are doing active physical manual work such as farming. But in one of the areas, which is Kilimanjaro, we have the rural versus urban prevalence being 10 to 5%. Now, the adherence also to anti-diabetic, which was also considered in Dar es Salaam. Dar es Salaam is my home city, but it's also the most urban city in Tanzania. We see that the adherence was only 60%. And the reasons for non-adherence or poor adherence were very common, and some of them were medication costs being very high, but also that some of the people would see that the symptoms would disappear. And so when they are asymptomatic, they would choose not to proceed. But also the medication side effects were also a reason. This is a very important real-time data survey that I would like to portray here. And as you can see, in 2017, the data for health information system, which gathers all the real-time data in our country, shows that we had 2.5 million people who were NCD patients. And in 2021, this number went out to 3.4 million. This is quite an increment, almost a 9.4 increment in almost 4 years. But when you talk about specifically hypertension, we can see the increment from 680,000 to 1.3 million, but for diabetes from 336,000 to 644,000, almost a double. This is quite a significant increment. Now, the NCDI report, which is NCDs, non-communicable diseases together with injuries report for our country, which has been done in a number of countries in Africa and all over the world, showed that these were the key issues when we talked about in Tanzania, when we want to have good package for management of NCDs, this is what we want to have. But when you look at diabetes right there, we have some specific things. Number one is we'd want to have a glucometer in our clinics, we'd want to have test strips, we'd want to have anti-diabetics in place, we'd want to have insulin, storage devices, normal saline, and the likes. But when you look at here the rural versus urban availability for the specific services, now I'm going to talk about only diabetes here. You would probably see that we have, now this first here row shows that It's a rural that is in the green and the urban that is in the blue. Now, we have for diabetes, it shows that only 21% of our health facilities had the specific that I have mentioned before. And we have 31% of the urban facilities. So you can see quite the gap in terms of, number one, the need. We have seen the progressive in terms of disease prevalence, but also we can see the gap in terms of service provision. The availability of uncivil services by health facilities and levels also, it shows now how our health facilities have been structured with, we have clinics, dispensaries, health centers, and tertiary hospitals. So you can see the availability of the services. When you look at diabetes, which is on the first part here, you can see that with the blue, which is actually dispensary, which is a large majority of the people, more than 70% of our population are in rural setting. And this is where all the dispensaries are based. But we only have 2% of the health facilities, which can actually provide for the services. This is another very pictorial presentation here, which shows the availability of diabetes mellitus services at district and regional hospitals, of which a majority of these are tertiary centers. And as you can see, the green indicates yes, and the red indicates no. And you can see how much we have the red on the map. This is a map of our country, and this is just the distribution of all these services. Now, the hallmark for all of this that I'm trying to say is that we had the NCDI report, and we do know that various risk factors sometimes mimic depending on the region, and sometimes we do have a lot of similarity between the north and the south in terms of risk factors and how they present. But the hallmark of the report, the NCDI report, it showed that 79% of the condition, the non-communicable diseases in our setting, were not attributed to the most traditional risk factors that we know about, which is unhealthy eating habits, physical inactivity, a lot of alcohol drinking, and a lot of salt intake, and the likes. So this is where my PhD actually is focusing on right now. We're trying to link whatever is very relevant in our setting, and a good example of this is Tanzania is a land that produces a lot of food produce. I showed you that more than 40% of our land is arable, and more than 40% of our land is being used for agricultural produce. But a good example is a report that came out in early this year that showed us more than 40% of our children under the age of 5 are actually stunted, which is quite evident of malnutrition. So there is a lot when it comes to the risk factors, a lot when it comes to the interchange of the risk factors towards the progression of the diseases, and especially diabetes. And this is what we're trying to explain through our study, but also we have seen quite a significant change in terms of the years. We have seen the numbers in terms of the increase in patients, increase in prevalence, and there's a lot of complications which I had to bring down the slides because there was a lot of information that I want to share. But the NCD program in Tanzania is what I want to talk about briefly during my closing here. Now, until 2004, there was no organized system or mechanism in terms that supported the availability of insulin in people in Tanzania. And this is both for type 2 that depended on insulin and type 1 that actually needed insulin for their survival. In 2005, we thought that the Tanzania Diabetic Association, which is an association based in our country that harbors a lot of the initiatives that deal with diabetes care in the country, it received a number of donor-supported projects, including a project from Life for a Child, and in 2009 also received another project that supported under the Changing Diabetes in Children to supply insulin towards children under the age of 18 and under the age of 25 in the country. This really transformed the accessibility and availability of insulin, but only for the younger generation. And so this project had not only a lot of technical and financial constraints, but also there's still some issues when it comes to the supply chain because most of the insulin being procured goes through the public procurement system. And there's sometimes a lot of delay in terms of how the insulin reaches the target audience, which is the patients themselves. These projects have included financial and technical support for provision of diabetes services in Tanzania, and with a focus on availing on insulin diagnostic services, patient education through the Tanzania Diabetic Association. However, with nearly 100 years since the discovery of insulin, Tanzania still has been dependent on these donor-funded projects. But more than that, since 2015, the country had embarked on a national NCD program, and not only had it supported these projects through also incorporating some of the public and government policies towards supporting these activities, it has given a lot of commitment. The country has committed towards this program, in which we see programs of screening being initiated by the government. We see also we have an NCD committed week, which had just finished. It's actually one of the few African countries that commits a whole week into emphasizing on non-communicable disease advocacy, campaign, screening, and the likes. But also, we have seen that diabetes care has been incorporated in the national health insurance systems. And insulin supply has also been made more available through a lot of policy transformations. These measures have been very successful in improving the accessibility and affordability of insulin and essential supplies in Tanzania, plus staffing, training, and patient support education. Tanzania has delivered the proof of the concept that a decade of donor-funded programs can provide a solid foundation for a government to make the transition towards an efficient and sustainable national diabetes program. Thank you very much.
Thank you very much. Yes, please come and sit down. So we have, according to plan, another 15 minutes for questions, clarification, discussion. I've got microphones here, which I can throw to any one of you. Who will open? Oh, there are many questions. Okay, there you are. And there you are, and then you will come later. Yes, go ahead. I think we'll take 2 or 3 questions, and then we'll move it to the panel. Just speak into the thing. Yes. Yeah.
All right. Thank you very much, sir. Thank you to the panelists, and especially my friends, PhD students. My name is Dr. Sadiq Abdurrahman, a Nigerian, also a PhD student at Autonomous University Barcelona. So I'm here with a team. Very soon we'll be on the hot seat like yours here.
Yeah.
Mine may not be directly a question, but I'm just worried, being from one of the low-income, middle-income country, I'm seeing a scenario that is also unwinding in Nigeria. Specifically, I'm from Abuja, the Federal Capital Territory in Nigeria. Mm-hmm. As we speak, I could see the area that also could be barrier to this issue of accessibility, affordability. It has been dwelled on extensively, especially with the earlier presentations. But the area I'm also much concerned, which is glaring in Nigeria, is around infrastructure, human resource. Particularly, there's a government policy that is going on, but the policy does not translate into budgetary provision for infrastructure in consonant with the WHO of 15% of the annual budget. In Nigeria, it's less than 3%.
Okay.
Year in, year out. So the other aspect I'm seeing also as a...
One more, yes, yeah.
Sorry?
Yes, please, yes, one more aspect.
Yes, is issue of universal health coverage. Most, like the last speaker said, access to the health facility as a first point. In some places, he said dispensary, but in Nigeria, the dispensary or the health posts are non-functional. So the next stage is the primary health care, which is also a big challenge. It's not widely geographically spread, so people find it difficult. And not only that, the human resource is not there, the availability is not there, and in addition to what they have just said. Thank you.
Thank you very much. There's give it to me. There's 2 points. It's about the staff training and the accessibility in primary healthcare level. We'll come back to you and give you the example from Tanzania, because they have tried to deal with that exactly as you are saying. The next one, please. Yes, go ahead.
Joost van der Meer, public health consultant. Thanks for a super interesting presentation and sessions. I'm really enjoying it, if I can speak of enjoying such a big problem. But I have two questions, if I may. I haven't heard much of the role of the cold chain that could play a role in the procurement, the availability and accessibility also for patients. And if someone can tell me a bit more about it, I can remember a Lancet editorial of a couple of years ago, but I don't know to what extent it plays a role still at this point in time. So if you can
thank you.
elaborate
So
on
the
that.
cold chain, yes. Mark? Molly, good.
Second question, what is the way forward? I'm inspired by George's example, but is that a general model, or can someone also elaborate on that?
All right, I will say something about that. Thank you. There was one more. We'll take one third one. Yes, please.
I have a question for George. And I'm not a doctor, so I don't know if this is a very random question, but what do you think, do you have any idea of what is causing the rise in NCDs, if not the more traditional, like metabolic or lifestyle factors? Is there any knowledge of in that area, or is research being done, or is it just a complete blank?
The risk factors. Okay, we'll take them as they came. So the first question was about, and maybe George, you can say something about Tanzania, how it started and how it is now when it comes to the physical availability in the facilities. And then what about the training? What has Tanzania done about the training of health workers?
So for example, this year, a good example is this year, we have had multiple trainings in terms of different cadres of NCDs. We train all levels of healthcare providers, and when you talk about how the program started, it has not always been all sunny, and it starts with a lot of opposition. It starts with people saying that there's a lot of people dying from HIV. Why are you trying to focus on first world diseases and all the likes? So even getting the data and information is one step, because before we used to assume that probably people in rural areas do not have NCDs and the likes. So it always starts with a number of issues. And I think, Hans, we were discussing before that the government would usually jump on if the stakeholders, which private entities, civil society organizations like Tanzania Diabetes Association, international stakeholders, developmental partners, and the likes would all come together and would put an agenda to the table.
Yeah. What about the training? What was very important was that actually about 2 or 3 years ago, it stopped from being a donor-funded vertical training program where you have people in training courses, the traditional way. You bring people together for 3 days in a place. And they managed to have the basic diabetes treatment training incorporated in the regular postdoc or continuing education in the National Institute as part of NCDs. I think that was, so it really became, it stopped being vertical, it became vertical. And the same one about the districts hospital. Now they've reached a stage that you have diabetes clinic in nearly all district hospitals. And now the preparation is that you can bring, maybe you can say something about that. What is the plan for the primary healthcare?
So one thing maybe to note that I have not mentioned in my presentation is for type 1, for example, we have specific clinics that have been focused only on type 1 diabetes for the care, for the management, and etc. And so when you tell me what is the future or what is the perspective of how this program is going to run, number one is the government has been committing funds towards accelerating the NCD programs in all levels, not only diabetes, but the likes. But a huge consideration has been given to diabetes because of priority from stakeholders, but also from other key people who are pioneering this movement. So the future looks like a very good private-public partnership, but that actually aligns with the people, because there is good uptake in terms of when the government is calling for screening programs, we see a lot of people showing up and the likes.
Yeah. It was when I interviewed some of the people in the diabetes program in Tanzania, they also said, yes, the data to the government, to convince the government that you can diagnose and treat diabetes with simple means, without specialists, endocrinologists, etc., with simple insulin was very important. And I think also what was very important is about 4 or 5 years when they really increased the national health insurance. You had the community scheme and you had the National Health Insurance Fund. And the National Health Insurance Fund was willing to supply insulin and the diagnostic strips for the people. And that basically stopped the need for the donations. That's important to note, because then anybody in Tanzania can pay the contribution and get their insulin supply sort of free after that. And that was a very big move towards universal health coverage. Even sometimes some of the donors, Life for a Child, stopped supplying free insulin, but said, okay, we'll pay the insurance premium for the patients that were registered with us. So that really moving this whole responsibility, not only of, also but supplying the insulin to the national system. A very good example. We have to stop here. We go to the cold chain. What can we do about the cold chain, Mark?
Sure. I mean, we, Access ourselves haven't really studied the cold chain and looking at it. Obviously, it is an issue within insulin, and it does, make supply, it is another challenge. But there were some studies done in the US where they looked at, they took, I think it was done at University of Florida, where they looked at the insulin from the distributor to the pharmacy, and they actually found there wasn't an issue per se in terms of the delivery. It didn't necessarily impact the stability of the medicines. And then WHO and MSF have done some studies to look at thermostability. And actually what they found is insulin actually can be kept at a much higher temperature than was first sort of thought. So, I mean, I think it's definitely, obviously there does need to be some sort of cooling. It can't be held at high temperatures for a long time. So it does, it is a more expensive process to move it and store it. But there are means, even beyond refrigeration. There's been research in, for example, Mali, where they found actually if you just have a clay pot with some water, it works just as well as a refrigeration process. So there are ways around the cold chain system as they are, but we haven't really looked in if it's really, a barrier to access per se in that way directly.
I remember from my time in WHO also that actually in reality it is rather stable. You can have it for 1 or 2 months out of the fridge. But then you say, okay, but on the package it says keep refrigerated. So then it was very difficult either for WHO or for the regulators to say, oh yes, the package says keep between 4 and 8, but actually up to 60 days you can store it outside. That is regulatory or to the doctors or to the patients a very confusing message.
Yeah.
I think it was only recently that Novo actually indicated officially that there was some non-fridge time that the product would survive.
But I mean, the other risk is freezing is actually the biggest risk to insulin. So the other, if it's too cold, that's an actual big problem.
You don't want the thing to freeze. Yeah. Thank you. We stop here. We go back now to your study. Ken, in 1 or 2 minutes, do you know anything already now about risk factors other than the ones we know?
Yeah, I think that's a very good question, and I would like to assume that the risk factors are very different depending on the setting. That is the first assumption that we're making. It's an hypothesis. But the assumption comes hand in hand with what we're seeing in Tanzania.
Yeah.
A lot of Tanzanians use firewood as a means, for example, of getting to cook food.
Yeah.
So we have a lot of indoor pollution happening in Tanzania. Yeah. And so one of the key questions that we're asking, and actually that I'm trying to study, is what is the impact of indoor pollution on the mother towards the baby? What is the impact of indoor pollution towards individuals who are fathers sitting in the sitting room getting the effect of the smoke? That is just one. I've talked about the issue of malnutrition. We have more than 40%. A report showed that children under 5 who are actually stunted, which is an indicator of malnutrition. We have spoken about the Barker hypothesis, and we probably presume that there are actually more factors that might be genetical, that might be actually interfering with the baby before they are being born, intrauterine, and the like. So there are many more factors when it comes to pollution. We've seen a lot on climate change, and there are areas which are highly affected by climate change, mining and the likes. We see a lot of actually idiopathic and non-conventional diabetes and renal failure in Tanzania in some of the settings. Yeah. And I would just want to make a very short story. I have a friend who is actually very athletic, who actually eats very well, and they have been on quite good routine of physical activity for quite a long time, and their BMI is very good, but they're pre-hypertensive and they've got type 2 diabetes. Yeah. And we see these trends in a lot of places, not only in Tanzania. So these are the questions that we have, and we're trying to get the answers.
Thank you. Very, very interesting. Listen, we have a few more minutes. One more question. Somebody here? Otherwise, I have one. Okay. There you are. Yes.
Thank you very much for the beautiful presentation. I'm Chembe. I'm from Malawi, a neighbor with him. And it's good to know that you have quoted some of the NCDI report. Happy to talk more about that after this. But I think I have a question. On one of the slides, you had shown that the overall price for insulin management is way higher, for diabetes management is way higher than the cost of insulin.
Oh, yes. Yeah.
And it looks like on one of the slides, the cost of insulin was about $10, but the overall cost was about $30 or so. And in my mind, I think bringing in more insulin is just one of the steps. We still need to think about the glucometers, glucose sticks, and other things. So I was just curious what has been done so far to ensure that we bring down the prices of glucose sticks, glucometers, and other things apart from the insulin.
Thank you. All right, who will take the glucose sticks? Yes. Let me first tell you, glucose sticks is a jungle. It's an absolute jungle. And I think patients would have to because the insurance pays some, you can't get them, the pharmacy don't have them, there's different types, and it's like an HP printer. So you buy the printer for cheap, and then the cartridges are very expensive. The same thing, these glucometers, which you have to use every sort of 2, 3, 4 times a day, ideally speaking. Okay, take blood and you put a little strip there. The strips can be $50 or $1. And you need about 60 in a month, or 60 or 100 in a month. So that's why on the slide that Mark showed, there was $10 or $12 for the insulin and at least $20 or $30 for the strips. And then some people have, Mark, you know that, they struggle, they have 2 or 3 meters, which then, and it depends which strip they can find to use. And then, of course, these meters are not fully the same, comparable, so that's already an issue. And as I said, it's a jungle, and people are getting very rich out of that. Mark?
That's a really good question. Can you hear me? Yeah, good. We just actually, after we did that in Tanzania, we also did the same study in a few other low and middle income countries, and I'm hoping to get it to a peer-reviewed journal very soon. But what's interesting, the one in Tanzania was with human insulin. What we've now found in where we've got analog insulin, actually the analog insulin is a larger component of the total cost than the testing. So I think there is a big difference because of the difference in price of human insulin compared to analog. So I think we can't assume it's for all insulins at all. We've got to differentiate here. And I totally agree, there's a lot of issues because people don't have the right meter for the right strip and whatever. And then even when companies put out a different meter, then even the strip that you had been using, even though it's the same brand, actually doesn't fit it and so on. What we really need, though, is countries to not only provide free insulin, but to also provide test strips and meters as well. That's what we've got to work for, and that's got to be part of universal health coverage. It's got to be part of national health insurances, and certainly in countries like Indonesia, where there is free insulin, Kyrgyzstan, where there is free insulin, now we need advocacy with evidence to show the unaffordability of the testing, and that people are not testing the recommended number of tests per day they should be taking. And I'm particularly talking about people living with type 1 diabetes here. I mean, really, that's what we've got to now advocate for. We have evidence now. I think really we have to push for universal health coverage to include everything, because it goes, as you say, it goes part and parcel, the testing with the insulin and the delivery device.
Yeah.
Really, this is a life and death medicine, and these are expensive items. they shouldn't be, but they are. And now we need governments to provide them all to really make a difference.
Thank you very much, Mark. I'm afraid we have to stop here. We are around here. There is still some time in the pause. I would like to thank our speakers, and I'd like to say what you said also is universal health coverage is the only way. I mean, through a social health insurance. The free market is not going to solve this. But in the meantime, so that's necessary for equity. But also, as you heard, for efficiency, there's a lot of efficiencies to be gained by buying the right things at the right price. And it's sort of a forgotten area. And from my own personal perspective, you know, I've been in essential drugs for so long. This is really this is the most difficult thing. This is now getting penicillin and paracetamol to the people is relatively easy for a week or for a few days. But lifelong treatment to basically for a killer disease, for a life-saving treatment, in such a monopoly situation at high prices, this is really the most difficult of all. If you have insulin properly arranged, I think your whole medicine system is probably okay. Thank you all for listening to us, and we are here for more questions. Thank you all.